Prashant, all yours.
Yeah, good morning, everyone. Thank you, Dr. Titial. I think in the previous session, we had a talk on the similar topic, and we heard a couple of talks on how we can enhance the diagnosis of corneal ulcer. My talk is going to be a little different, and I'll be giving you some clinical scenario where the clinical diagnosis and microbiological diagnosis do not match. I do not have any financial disclosures to make related to this talk, and let me begin with this first case who presented to us with the history of 1 month duration. There was no history of trauma, no history of similar episodes in past, and the clinical picture was a kind of a disciform edema in a paracentral and central cornea. Now, based purely on the presence of edema, this patient was thought to be caused by herpes simplex virus keratitis and was started on treatment with prednisolone acetate with acyclovir and hometropine eye drop. In 1 week, this patient showed significant response. The same treatment was continued, and you can see that over 1 month period, most of the edema has reduced. The keratic precipitates are there. But then there was a worry about this area where there is a chalky white deposit on the cornea, and there was an area of epithelial defect. When we saw, we took the corneal scraping from this area, and the microscopy revealed plenty of acid-fast bacilli, and the culture growth was Mycobacterium abscessus. Now, where did we go wrong in this case? And I think if you look carefully, right from day one, it was not a uniform disciform edema. There was an area which was showing suspicious lesions. They started worsening, and at a point where we took a scraping, obviously there was an epithelial defect. And only when we paid attention to this lesion that we were able to pick up the diagnosis. Let us take another case. Again, a patient presented to us with a long history, circumscribed corneal edema, endothelial, large pigmented keratic precipitates. I am sure that many of you will think it is herpes simplex virus keratitis and will treat with corticosteroid, and so we did the same. But on day 11, we noticed that while the edema is subsiding, the patient developed a large epithelial defect. We didn't pay attention to that, continued the patient on corticosteroid with prophylactic antiviral treatment, and on day 31, the patient turned out to be a frank ring infiltrate, which on corneal scraping showed multiple acanthamoeba cysts. And if you review the literature, you will find that all cases of acanthamoeba keratitis are described as pre-treated with corticosteroid in large number of the cases. Now here again, where we did go wrong, if you have a patient of herpes simplex virus related stromal keratitis, you will not see development of epithelial defect like what we saw here if there is an adequate antiviral prophylaxis. And at that point of time, we should have reviewed the clinical picture and possibly subjected the patient for some investigation, either confocal microscopy or. So lesson 1, even in cases so-called responding, do not lose sight of good clinical examination. Everything that look unusual, we should pay attention to and give a thought, where are we going wrong? And sometimes these subtle signs are very valuable in an early diagnosis. We should not lose sight of microbiology, although we heard a lot of talks on AI, other diagnostic modalities. Let me tell you that most of these deep learning tools are built on very classical cases. But if you present this case to any machine learning tool, I am sure the diagnosis is going to be based on what kind of input have you provided to the deep learning. Confocal microscopy, while it looks very good tool, it requires experience in interpreting the images. Let me give you another series of 3 patients who again presented with a circumscribed corneal edema. And in all these 3 patients, the characteristic or some unusual history was that they presented to us with a history ranging in weeks to months, and some of the patients presented with history of several years. They were treated as herpes simplex virus keratitis, corticosteroid started, initial response, and then as the corticosteroids were tapered, they started showing worsening again. So they were not off the steroid for a long period of time, and they did not get a complete remission of the disease. And our journey into establishing the diagnosis began with this patient whom we ourselves treated for 3 months. And then when we got extremely frustrated, we said, anyway, the lesions are central. Why not to do penetrating keratoplasty and get a biopsy? And we saw what we call as a microsporidia. And in all the 3 cases that I showed, corneal scraping showed microsporidia. They finally had to undergo penetrating keratoplasty. So we learned a lot from the microsporidia, and now we have published multiple papers describing clinical features of microsporidia. I think one thing that stands out very clear in establishing the diagnosis is prolonged history, and that helps you catch and suspect this organism. Let me go to my last case, a typical fungal looking corneal infection. Microscopy also showed filamentous lesions which were suspected to be fungal etiology. However, this patient worsened very rapidly. Within week to 10 days, the clinical picture, which was localized to inferior paracentral area, became a total infiltrate. And that gave us a clue that we probably are missing. And before this case was seen, we were already aware of pythium. We compared the micro or the morphology of the fungal filament and found that we are dealing with microsporidia. This was all courtesy to Savitri, who looked at some of the unidentified fungal filaments that we had in our stock, and DNA sequencing helped us to characterize this pathogen, how to diagnose it, and even how to treat medically this organism. So lesson 3, unusual features point to mystery yet to be unraveled. In both the cases that I showed, a prolonged history and lack of sporulation was picking point for us to establish diagnosis. So far what we have discussed, no response or worsening on medical therapy after an appropriate therapy are because of the missed diagnosis and infection by uncommon organism. But there are other causes: inadequate therapy, drug resistance, and presence of aggravating factor. If you use a systematic approach, you will be able to arrive at diagnosis and unravel the mystery of non-resolution. Thank you very much for your kind attention.
Thank you, Dr. Garg, for such thought-provoking